My name is Terry Mamounas. I'm the medical director of the Comprehensive Breast Program at Orlando Health Cancer Institute in Orlando, Florida. So this is an important question of whether every patient should have an axillary ultrasound with a biopsy of any abnormal lymph nodes prior to surgery or potentially prior to neoadjuvant chemotherapy. And the answer is progressively more and more patients actually do undergo axillary ultrasound. In our practice, we do that pretty much routinely. Every patient presents pretty much with invasive cancer in the breast, gets an axillary ultrasound as part of the imaging, the preoperative imaging. And why is this important is because we have a better ability now to identify abnormal lymph nodes in the axilla. Because depending on the body habits of the patient, sometimes you cannot feel even abnormal or enlarged lymph nodes. Now, the axillary ultrasound can give us a good visualization of the lymph nodes, and more importantly, whether there is cortical thickening. That's one thing that we're looking for. In other words, the cortex of the lymph node gets thicker, and that's usually abnormal beyond a certain size. Usually about up to 3-4 millimeters is normal, but then beyond that, it becomes abnormal. The second is whether the lymph node loses its hilum. And when we talk about that is the lymph nodes are like kidney shape or bean shaped structures, and they have an opening where the vessels come in, and that's called the hilum. But when tumor grows into the lymph node, sometimes the hilum eventually will be lost, and the lymph node becomes more like a sphere, like a round mass. So if we see that, that's a pathognomonic sign of involvement of the lymph node. Now, nowadays we have made significant progress not only in looking at the lymph nodes and see if they're abnormal, but also biopsy the abnormal lymph nodes that we think that by ultrasound. And if the lymph nodes are proven to be involved at the time that we biopsy them, we typically at the time of biopsy we drop a clip in the lymph nodes. That way we can identify that lymph node and remove it. Now, if the plan will be to do surgery first, and if the decision, if the node is positive, is to do an axillary dissection, there is not much benefit of having the clip there, except that we can always X-ray the axillary lymph node dissection specimen and make sure that the clip node was removed, that it was taken out. But in general, in an axillary dissection, it would not be difficult to remove the previously biopsy lymph node. But when this approach is very useful is for the patients that undergo neoadjuvant or preoperative chemotherapy before surgery. And the reason for that is that because the lymph nodes may normalize after the neoadjuvant chemotherapy, and therefore then instead of doing an axillary dissection, we will propose to the patient to start with a sentinel lymph node biopsy, trying to see whether pathologically the involved biopsy lymph node has now turned normal or negative. And if that is the case, then we typically will not complete the axillary dissection. However, in patients that have documented positive nodes before neoadjuvant chemotherapy, and now they're normalized clinically, when we did clinical trials, we found that the false negative rate of the sentinel lymph node biopsy was higher than if we did the sentinel lymph node biopsy up front. And to improve on that, we then started to say, well, maybe if we remove the node that had the clip in it, in other words, the node that was positive before, and that node is removed along with the sentinel lymph node biopsy, then what we found was that this improved dramatically the false negative rate from about 12 to 14% down to about 2 to 4%. So that makes the sentinel lymph node biopsy much more accurate if you remove the clipped node. And of course, to do so, the node has to be clipped before neoadjuvant chemotherapy. So by doing that, and the reason for that is actually because in these cases, in about 25% of the times, the clipped node, the node that was clipped and biopsied before, does not appear to be a sentinel lymph node when we do the lymphatic mapping, where we inject the blue dye and the isotope and trying to find the radioactive or blue nodes in the axilla. The clipped node 25% of the times is not blue or radioactive. Therefore, you would not have taken this lymph node out if we didn't know about the clip. But now we can localize the clip with a radioactive seed or with a radiofrequency chip or with a wire localization or with a magnetic seed and remove the clip node and improve on our false negative rate. In other words, it had made that procedure much more accurately and allows us to avoid an axillary dissection if the sentinel lymph node is then negative and the clip node is negative. And actually, the clip node is a more accurate representation of what's going on in the axilla than the sentinel nodes. In other words, if the clip node that was positive before becomes negative after neoadjuvant chemotherapy, there's a good chance that there is no additional nodes that are positive. But we do combine the removal of the clip node with the lymphatic mapping and the sentinel lymph node biopsy to further improve on our accuracy. So not everybody perhaps has an axillary ultrasound before, either before neoadjuvant chemotherapy or at the time of diagnosis, but progressively I think that has become more and more of a standard, or at least in our practice, we employ on an everyday basis.